Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel. Today I want to talk about a pet peeve of mine. It's really common and commonly known in the world of medicine that each joint has a specialist doctor. You got a knee doctor, you've got a hip doctor, you've got a back or spine doctor, you got a neck and shoulder guy, and you know that's serving many people okay. But the brilliance of orthopedic acupuncture is that we work from the idea of the structure, not the structure, but the function of the body affecting the structures. So you don't just treat a knee pain by treating the knee. You realize that the knee pain is a symptom of a postural or movement pattern that is usually coming from the hip or possibly the ankle or both that are putting stress on the knee. And because we do that, because we look at the way the body moves, we can very quickly assess and treat a problem like knee pain. And when I say quickly, I mean first treatment gets results. It's not common for me to need to treat knee pain more than a few times and have the person pain-free. Same thing with things like sciatica. If your sciatica patients aren't getting better in 2 or 3 treatments, and usually for me it's the first one, but if they come back and they were only good for 4 or 5 days, then I'm looking for trigger points. But typically my sciatica patients come back to me with little to no sciatica. And knee pain. I just treated an 82-year-old last week for her knee pain. She had some swelling above the knee, and she was pretty much told by the doctor that there was nothing that could be done because she's bone on bone. And she has this little bubble above her knee and some lateral knee pain as well. And after her first visit, almost all of that swelling is gone. I saw her for her second treatment of her knee pain, and she just had some vastus lateralis pain. There was a trigger point there. I'm pretty sure that after yesterday's treatment, she will be almost pain-free or, very close to pain-free or pain-free completely. We'll see. I went gentle on her trigger point. I just lined up some needles in it. So if you think functionally, you should be able to figure this stuff out and treat it really quickly. I saw somebody with shoulder pain first visit and his pain was gone. I only treated him once and his anterior shoulder pain is gone. He had been dealing with it for a long, long time. His wife and some other patients of mine surrounded him and told him he must go. And so he came to see me and his shoulder pain was resolved in one treatment. Many times I see shoulder pain resolve in one treatment. Because you have to think functionally and not structurally. And that's the problem with Western medicine. That's the failure of Western medicine. Your knee is not in pain because it has a cortisone deficiency. You are not in knee pain because you haven't had enough Advil. Your inflammation is not your knee inflammation is not caused by an infection. There is a reason you have pain and inflammation in the knee, and it's not just unknowable. And the way our world treats knee pain is as if that pain and inflammation is some idiopathic disease that has infected the knee. And I know that doctors don't think that that's the case, but that's how they treat it. You know, they look at it, they say, yep, it's swollen. Yep, you have arthritis. Nothing's torn. You have pain. Go do some physical therapy, lose some weight. They have nothing to do for you until you need a surgery. And they'll gladly replace it. And then you may have pain anyway. You know, I think the statistics are like 50-50 because they focus entirely on structure and not the movement patterns that have led to poor tracking of the patella. So we see the same thing with SI joint. And this is like a big peeve of mine. You have orthopedic acupuncturists sticking needles in the SI joint for SI joint pain. You have acupuncturists sticking needles under the patella for knee pain. You know, and on and on. You have acupuncturists teaching courses on how to needle the joint, how to needle the ligaments. Maybe they're needling tendons. I don't know. That's not necessary. And it's painful, by the way. For the patient, it's not fun. And it's certainly not getting like a one treatment result if you're just needling into the joint. So I'm not a fan. And I'm really in the Carl Lewit camp that if you treat the site of pain, you are often lost. You are completely missing the big picture. And, you know, you can't be blamed because you're thinking like a medical doctor, and, you know, that's to be respected. I have a lot of respect for medical doctors. They learn a lot and they do a lot for people. And certainly surgery is way more advanced than what I'm doing with acupuncture. So I have complete respect for surgeons and orthopedic doctors. I just think their education is lacking because it didn't include movement patterns and muscles. They are more concerned with the joint, the tendon, and the ligament, all the white stuff, but not the red part, the muscle. So they're missing out. They're completely missing the point. You can't see a short, tight muscle on an MRI any differently than if it's completely healthy. It doesn't look different on an MRI. But if you have a short, tight muscle that's putting tension on maybe the patella and changing the tracking of the knee, you're going to have rubbing, inflammation, pain, eventually some sort of arthritis. And maybe that rubbing will increase tension on the meniscus. And then you do have more soft tissue damage because of muscular imbalances of the muscles that cross the knee. And possibly because of weak stabilization in the hips. So SI joint pain. Why are we sticking needles in the SI joint? It's, in my opinion, if you are sticking needles in the SI joint, you are raising the white flag of surrender. You have admitted failure, because if you're sticking needles in the SI joint pain into the SI joint, you are realizing that you don't know why there's pain in the SI joint. So I want to talk about that. The SI joint is that joint where the sacrum meets the pelvis, the sacroiliac joint, the iliac crest, the sacrum. The sacrum meets the iliac crest. There is just this little tiny joint there, and the sacrum can nutate or anteriorly tilt to lock in place, but there's not much to stabilize that joint. It's a small little joint that has to be stabilized. the full weight of the body comes down onto the sacrum and then down into the pelvis, and the weight has to distribute between both of your legs. And the same thing if you're standing on one leg or you're landing on one leg as a runner, all of that force generation goes right to the SI joint, needs to be strongly stabilized. And it needs to be stabilized really dynamically. Like instantaneous changes of weight need to be met by a feed forward mechanism and by stabilization from muscles. So you have fascia. The SI joint has a lot of proprioception to help the body to dynamically stabilize that joint under all the forces that it's going to encounter. Just walking to your kitchen, your SI joint has to dynamically stabilize. Right, left, right, left, right, left. That's a lot of work, and your body just knows how to do it. It's a built-in pattern. But what happens when you age and your hip flexors are tighter, especially your psoas, iliacus, TFL, and now you have an anterior tilt on your pelvis? Isn't that going to put a lot more strain on that SI joint? Now you've got muscles in the back that are working really, really hard to maintain stabilization of a joint that's being pulled forward by the hip flexors in an anterior pelvic tilt, the lower cross syndrome of Janda. Now you've got a lot of pressure there, right? What's going to counterbalance that anterior tilt and strain on the SI joint? Primarily, it's going to be the glutes, the deep rotators like the piriformis, the gemelli, obturator internus. You're going to have your hamstrings and your adductor magnus trying to stabilize the SI joint. You know, the sacrotuberous ligament, the from the sacrum to the ischial tuberosity, sacrotuberous ligament. You have that important ligament there, and that ischial tuberosity where it attaches has connections for hamstrings and adductor magnus. So hamstrings get tight when the SI joint is under strain. It's the hamstring's not just tight because of an anterior pelvic tilt. It's not just stretched. It's actually the hamstrings are working really hard against the anterior tilt of your pelvis. So there's an actual stabilization reason that you see hamstrings tight on people with low back pain. And the glutes and the deep rotators, the piriformis works so hard to correct for an anterior pelvic tilt. And for many of us, we have strengthened those muscles enough to correct for the tilt and to keep us stabilized and keep our anterior tilt under control. And that's a lot of work to maintain that and to keep the strain off of the SI joint. So when you have, and the erectors, by the way, let's talk about the erector aponeurosis. So you have all the spinal erectors that come down to the sacrum. All of that aponeurosis goes way down into the sacrum. Your spinal erectors have a lot to do with SI joint stabilization. So they're going to tighten up as well to help stabilize the SI joint. Now, remember how I've talked about how the psoas pulls the lumbar spine forward into an increased lordosis, and then those erectors in the QL are tightening up to maintain stability of the lumbar spine. So they're being pulled forward by the psoas, so then the erectors and QL tighten up to counter that force being pulled forward, and they're trying to stabilize the SI joint. So anterior pelvic tilt, this is why Janda says most problems start at the pelvis. And I would say the psoas is a big part of that. So, so think about, why would there be pain at the SI joint? It's not the SI joint that's the problem. It's all of those factors I just mentioned not in balance, not working properly. And now you've got pain at the SI joint. But you don't treat SI joint pain by sticking needles in the SI joint. I mean, that's what I'm saying. You're throwing up the white flag of surrender. You are admitting that you have no idea why the SI joint hurts. And yes, there are people who've had trauma to the SI joint. There are people who have had auto accidents that I have treated with laxity in those ligaments, and prolotherapy can be good for that. That's such a small minority of the people that you're going to see with SI joint pain, though. So let's set that aside, because, I know the people out there want to just tell me about how they have a patient who had this exact, issue with laxity of the ligaments or whatever. That's not most of your people. And that's not most of your people with low back pain. So, you can talk about that one. I have that patient too, and she's doing really well after prolotherapy, by the way. But we still have to work with all the SI joint stabilizers. We have to still work on her anterior pelvic tilt. We still got to work on all the functional things that are going to take pressure off the SI joint. If you struggle with treating sciatica, remember that the deep rotators that stabilize the SI joint have gotten super tight. Now they're hitting the sciatic nerve. And why are they super tight? Because of an anterior pelvic tilt. So if you're treating the psoas to take the tilt off the pelvis, their sciatica is going to be reduced in the room, like right there. So you should be treating those deep rotators because they've gotten super tight and they may have trigger points, but you should be correcting the anterior pelvic tilt, especially created by the psoas. When you start treating psoas for sciatica, you're going to see a lot of people get better really fast. If they're not getting better fast, it's because you haven't corrected the anterior pelvic tilt or haven't even started trying to do that. You can't keep going to just piriformis for sciatica. That's like acupuncture school 101 is like sciatica, gallbladder 30, hit the piriformis, and they're going to be better. But that's just not the case. You got to correct the anterior pelvic tilt. You've still got all those deep rotators underneath there that are straining. You've got the hamstrings that are straining. You've got the erectors, the QL, all of that straining to stabilize the SI joint. As long as the SI joint is under strain, all of that tension in the deep rotators is going to keep coming back. That means their sciatica is going to keep coming back. And maybe that's a good patient to have, I guess, if you just want to see them for many, many treatments. But if your goal is to get them better, then you're kind of failing them. And sticking needles into piriformis in the SI joint is not really a long-term strategy. It's a white flag of surrender. So you don't need to keep sticking needles into things that hurt. If you're not getting good results on 1, 2, 3 treatments, then you don't understand the problem. You're not looking at it functionally. You're not considering the possibilities of ways that joint could be causing pain. So just sticking needles there, you've openly admitted to yourself that you really don't know why it hurts. And you should be able to know. You should know these things. It's knowable. I'm trying to think of other things similar where people are sticking needles into joints. Ankle strains and sprains. Just because the ligament got injured doesn't mean you got to stick a needle in it. Fix the function of the muscles that stabilize that joint so that there's not so much strain on the ligament. The needle is not going to do anything different than, it may actually increase inflammation temporarily, but the needle doesn't have magic in it that's going to make the tendon heal. The tendon or the ligament will heal. Well, the ligament's going to heal in its own time, but the ligament has a better shot at healing if you take the strain off of the joint that led to the problem in the first place. So fix things like the peroneals and, those the dorsiflexors of the ankle. Fix the antagonists of those muscles. Fix the joint, fix the joint range of motion. and then they will feel better. One of my patients had a roll sprain 10 days before she came in for her treatment, and she walked out with no pain. We can restore function with needles. We have like one of the best professions that you can imagine if you're interested in helping people. We help people out of pain quickly. And for some reason, our profession has had a lot of people who are still focused on structure more than function. And Vladimir Janda was there telling everybody, fix the function, fix the joint mobility and the range of motion of the joint, stabilize the core. You know, he would say, regulate the extremities and then stabilize the core. Fix the problem that has pain in the extremities, then focus on strengthening the stabilizers so that the problem doesn't come back. But first, get them out of pain. Treat the dysfunction of the joint that's causing pain. Then consider the stabilization issues that led to the problem and start working on those. And in that case, you're working on things that are not causing pain. So, you know, the focus on assessment looking for pain, or assessment only looking for the things that are, you know, causing that one pain, are missing a lot of the point. Yes, get them out of pain. That's like the number one priority, of course. But what about thinking about why it even happened? What is happening structurally and posturally that led to the problem? How about let's start looking at postural things that we can improve? And then what do you do for your patients that aren't in pain? You should be improving their quality of life by improving their hip mobility, their neck mobility. You know, how many of your patients have to have a backup camera in order to park because they can't turn their head that far? And that's just like, that's normal for them, but it doesn't have to be like that. And should they have to be in pain for us to be thinking about how we can improve that? I just think we're missing something. Sometimes I do like to read the acupuncture groups on Facebook and see what people are talking about. And I like to see what their cases are and what they're doing. So often they're just muscle testing, and they don't really know what they're looking for. They don't know why they're looking for it or what the possibilities are. They know what the symptoms are, and the symptoms don't seem to be telling them anything. So they're just testing everything and seeing what's weak. And really, if you have somebody with pain and they talk to me on the phone, I already have an idea of what's going on. I might muscle test to prove the theory, but if you understand how the body works, you should be able to just know, like, what's the most likely cause of those symptoms. And if somebody has nerve symptoms and you're ignoring it and treating it like it's just a muscle issue, then you're completely missing something. Sensory nerves are a big key to where to look for the problem. When people have burning, tingling, numbness, even shooting pain, think about what nerves are going there, sensory or possibly even motor sometimes. And where would those entrapments be? You know, just muscle testing your way along it's fine for beginners, but you know, at some point you really should be able to hear what the symptoms are and say, okay, there's a couple things in my mind. This is what I want to rule in or rule out. You know, are we looking at something at the spine? Are we looking at something in the shoulder or the hip? Are we looking at something, you know, like when I'm thinking about nerve entrapments, I'm thinking like, well, point to where it hurts. Tell me the symptoms. Is it worse when you bend in a certain direction or when you twist your body? I just had a patient this week. She's one of my regular patients, but she had this weird random tingling, numb, burning thing on the outer part of her heel. And I mean, it's unusual for her. But I thought, well, it seems like the sural nerve. let's check the gastrocs. Let's see if I can find an exquisitely tender spot in the gastrocs where it's possibly irritating that sensory nerve that goes into the lateral part of the heel. And I found a couple spots in the lateral gastroc, stuck needles in them and put stim on them while I was treating her other usual stuff. She comes in for just regular maintenance usually, so I thought, well, let's just continue on that sort of stuff, back and hip and things like that. She likes to be really active, and so she texted me the next day. She said, "Whatever you did, it was perfect. My foot doesn't hurt anymore. I have no more burning, tingling, numbness, anything. You hit it perfect." And it's because I'm thinking about the sensory nerves as much as I am the tendons and things. And if you dismiss symptoms like burning or tingling and you just think it's an ischemia caused by muscular tension, you're probably missing something, and it's going to take you a lot longer to get the results you're looking for because you're just thinking about what muscles are going there. If somebody has burning on the forearm, tingling, it's probably a cutaneous nerve. And if they have anterior shoulder pain and burning in the forearm, then it's probably musculocutaneous nerve entrapment by the coracobrachialis. And that should be like the first thing you check for. And you shouldn't have to go through like 10 minutes of orthopedic assessment of their whole torso, core stabilization, joint mobility, etc. You should already be sticking your thumb in their coracobrachialis and see if it hurts. So we have work to do. We have one of the best tools at our disposal for treating pain and doing better than many of the doctors because they don't have the tools we have. Many times they have to wait till there's a surgery that's possible, or they have to medicate. And as we know, medication is not going to resolve an anterior pelvic tilt, putting strain and pain into the SI joint. The anti-inflammatories are not the solution. Your SI joint is not Advil deficient or cortisone deficient. We can do better, and we many of us are doing that and doing great, but there's a lot of people who are kind of stuck in this mindset of assessing just like a medical doctor, and the medical doctors are the ones who are missing the missing link of function over structure. So there are probably times where I'm treating structure as well. I'm trying to think of one. Well, I think of a good example might be segmental treatments for the spine, because I'm feeling for sensitized spinous processes, and I'm bracketing on both sides of the spinous process for some electric stimulation to try to reset that segment to make it less painful and less active. So that's kind of local treatment for an activated segment. But in many cases, I'm not treating local. I'm not sticking needles into joints. I'm thinking functional. And believe me, if it was taking me 5, 7, 8, 10, 15 treatments to get the result I'm looking for, I might be listening to some of what you guys are doing, sticking needles into joints and ligaments and stuff. But consistently, I'm seeing people better in just a very few treatments. Sometimes one, and it might have even been a really chronic issue. Sometimes 1-2 treatments, they're way better, or they're completely resolved. And it's because I'm thinking structurally. So I'm not flailing here. I'm saying, listen, look at the function, and you're going to get faster, better results. And you're going to start understanding what you're looking at when you hear it from your patient without having to even muscle test. Muscle test should just be to confirm what you think. So often, if I think there's a problem with the psoas, I'll have the patient sit on the table, cross their arms so they can't stabilize on the table, lift the knee up to my hand and press up. And I'm looking at how they compensate for that pressure to know if their psoas is involved, if their psoas, and the affected side is usually much weaker, and the patient is like stunned at how weak that side is, because they had no idea that their psoas was that weak. They can use other hip flexors to do a lot of the normal day-to-day things, but I'm doing that to confirm the diagnosis, not because I'm searching for the problem. And that's the difference. If you're sticking needles into the site of pain, you're often lost. So, the remedy is to start looking at Vladimir Janda, start understanding how the upper cross and lower cross syndrome are a pattern that can lead us to understand dysfunction that leads to pain. And it leads us in the direction of correcting posture that will eliminate pain. So, a bit of a rant today, but I'm just kind of annoyed. I feel like I'm a broken record on a lot of this stuff. I've been saying it for a long, long time, and then I go into these forums, and it's like, they're still like floundering, and just well, I'm muscle testing this, and this is what the range of motion was in this direction, and this was, and then their neck can do this, and then their back can do this, and and then they give a history on the relationship they have with their mother, and then they don't know why they're not getting any better. And it's just so frustrating to me. And then even worse is like, I'll put in like 2 sentences of like, check this. Because I don't want to go into a whole diatribe, especially in someone else's group. I just like say, check this. And then it pretty much gets like completely ignored. And then, and everybody comes in with all of their do this and make sure that they drink tomato juice at midnight and, all of that sort of stuff. And then, and it just gets completely ignored. So I'm taking advantage of the fact that I have a podcast, and I'm going to just like, complain here and, and say what I'm going to say. And you can't comment. you can't block me. Anyway, so, yeah, so look at that stuff. And, I'm really not into self-promotion. I'm really not. I'm into great results, and I really want my colleagues in my profession to get great results, so that before I leave the planet, we see a shift in the way we treat pain for people, so that many, many more people can have a life without pain. My 92-year-old patient, I got a cool message on Instagram from her physical therapist saying, I have a patient of yours, and she says you have changed her life, and she has no pain. And, and this is a patient of mine that I've been seeing for the past year, and probably started seeing her once a week for a while. And then it was once every 2 weeks or 3 weeks. And now she's like once a month. And she came in, of course, she couldn't stand up straight, and she had back pain. She's 92 years old. She had back pain, but when she was young, she was a tap dancer. She's very active. She's like a social activist and really energetic person, very happy, upbeat personality, really fun to talk to. You wouldn't know she's 92. You'd probably think she's 70. And she no longer has pain, and she stands up straight. And she was out with a friend. She told me this week she was out with a friend, and the big band song came on, and she and her friend were able to go out and dance, and then she didn't pay the price for that the next day. She's been feeling really good. So right now I'm working on some of her foot neuropathy, some of her numbness in her legs and feet. But that was always something we kind of put down the line because she was in so much pain from her back. And now she's going, she has been maybe months without back pain, without a setback. Because in the beginning of that session, of those sessions, she would feel better, and then she would have some bad days, and she's having good days and some bad days. And she's 92, so like, I'm not expecting her to be out of pain immediately, but I just want to say, she's like, it wasn't tons of treatments. Okay, if I looked, it's under 20 in a year. It's probably something like 10 or 15, and she's doing really, really well. And it's because I did structural stuff. I thought about it structurally, and we didn't really even worry about her spine, which had been fused. And, she had all sorts of stuff going on in her low back at some point. I treated her glutes and her piriformis and her TFL, things like that. And psoas, of course. And she's doing really, really well. So, I'm not making this up. And it just frustrates me because I feel like everybody else should be seeing quick results, quick assessment, and get to it and get great results really quick. And I hate to see people flailing, and I feel like I'm banging my head against the wall because I try to help in the comments and they just ignore me. But I'm gonna keep doing what I do. I'm just gonna keep saying it, and maybe one day somebody will listen to my podcast and, oh, Rich knew. So anyway, that's it for this week. Sorry for the rant, but I sometimes I got to be a little controversial, I think, and at least get the conversation going. So have a great week.